Um, so, welcome to the Health Informatics Seminar. I'm David Potenziani. I am playing host today. Please remember that today's seminar is being recorded. Do mute your microphone while we're listening to the presentation. However, today, in particular, feel free to break in at any time. Feel free to disagree. Our guest speaker would really like to talk with the audience and have a full and rich conversation. If you prefer to post things in the chat, I'm happy to relay them and occasionally enhance them. So I'll turn it over to Ed Hammond to introduce our guest.
Thank you, David. It is a delight for me to be able to introduce our speaker for today because he was a friend, a colleague, and a boss. And I still view him in all three of those categories. But he's a family physician who works to link communities, health care, and public health. A graduate of Harvard Medical School in residency training and fellowship training in family medicine at Duke, he founded the Duke Division of Community Health, the Duke Center for Community Research, and was chair of the Department of Community and Family Medicine for more than 20 years, co-designing and managing community health programs across Durham and surrounding counties. He now serves as Emeritus Professor of Family Medicine and Community Health at the Duke School of Medicine and Adjunct Professor of Public Health Leadership at the UNC School of Public Health. Lloyd was a founding co-chair of the Community Engagement Steering Committee for the NIH Clinical and Translational Science Awards, served on the NIH Council for Complementary and Alternative Medicine, the National Institute of Medicine Committee on Integrating Primary Care and Public Health. He was the HHS representative to the Federal Interagency Leadership Innovation, was partnered with NCD HHS and over 3,000 community organizations to implement a statewide program that has linked over 100,000 people for community services. He was also a member of the National Academies of Medicine, working on assessing meaningful community engagement, the NIH CDC ATSDR Workshop for Principles of Community Engagement, is an editor of the Journal of Clinical and Translational Science, and leads the Practical Playbook, which has gathered and shared methods for effective multi-sector partnerships for health across diverse communities. His work has spanned 70 countries, wow, including serving as an appointed member of the International Medical Workforce Collaborative, and was the founder of the Duke Salzburg Seminars in Family Medicine and Public Health, for which he has received the Grand Declaration of Honor from the Republic of Austria. I could tell you lots more stories, but I want to save the time for Lloyd. Lloyd, thank you so much for doing this, and we're looking forward to your remarks.
Well, Ed, thank you for the introduction, and folks, thank you for the opportunity to have this discussion with you. I should probably preface my comment saying almost everything I learned about informatics, I learned from Ed. If I get it wrong, it's on my head, not his. I'm still learning from him. What I'm going to do today is share a perspective on health and healthcare that is probably new to many of you. It's an old concept that's actually been rattling around in communities for several decades and actually picked up national attention and federal attention actually 4 administrations ago and grew into a bit of a national movement about rethinking health and healthcare and how do we avoid chronic disease and how do we build trust, that really took off after COVID and then got picked up by the current administration. I'm going to try and explain where some of that comes from, and if I can, some of the rationale behind some of the changes underway. I'm not trying to defend actions. I am trying to give some of the background and history of where folks are coming from and why I think there's a very large rearrangement underway in health and healthcare in which data and informatics plays a really critical role, but in particular in partnerships with communities and around building trust. So I'm going to try and make sense of that. I've done this a lot, and my experience is that it makes sense in short bites and starts making people confused in large bites. So please interrupt. I'll ask questions of you just to make sure you're tracking, but interrupt, disagree. This is a dialogue. I should probably add that I'm Quaker, and if you don't know what that means that I'm very comfortable with silence. So if I ask questions and nobody answers, I'm just going to sit here until somebody has the courage to voice a thought, because the discussion is really important. So first question, can you see the screen with the title?
Yes.
Yeah, okay. So I'm going to walk my way through. Thank you. At least I hope I'm going to work my way through. Yes. So the first point I want to make is, and we've known this for decades, is that where you live matters a whole lot. This is an old CDC slide, been published and republished in Health Affairs and elsewhere. And it hasn't changed much. I'll show some of the patterns. But it's basically life expectancy at birth at the level of the US Census Tract. And this is a 5-year conglomeration. Blue means that people are living around, dark blue, 80 to 90 some years of age. Red means it's around 55 to 75. So it's big variations in longevity across the United States. And just to get us started, my first question is, do you see a pattern in this map?
Yes, the South shows up.
Doesn't it? Yeah, it's so folks in the Southeast, and this is a long-standing pattern, tend to die younger than folks in other places. There are a few other red spots on that. And where else do you see?
Appalachia shows up.
Appalachia is deep in it. And some of the rural areas in the West in California show up. Okay. Let's take it more.
Is that Arizona or somewhere with Indian tribes, I wonder?
Well, that's good because this is everybody, so the tribes are in there. We're going to drill down into this a little bit because this question of why is really fundamental. Well, before I move on, anyone want to postulate a connection between this map and voting patterns?
Red reflects red?
Red reflects red. I'm not saying I'm just noting the correlation, not saying
correlation does not equal causation, right?
Exactly so. But we will see this show up again and again, which just raises questions. And as Ed mentioned, I've worked with several thousand communities, and I think there's truth to that association, but it's complicated. So here's change in patterns. This is change in females. So this is women. Mortality rates from 92-96 to 2002-06. Now we're at the county level, where red means that women are dying sooner, and blue means they're living longer. First question is, has anyone seen this map before? Isn't that interesting? So the overall pattern is that the lifespans of women has plateaued, even getting a little worse. And it's particularly getting worse in roughly half the US counties. Women are dying younger than their mothers. And so first thing that fascinates me is this is big news I'm kind of a family doctor in public health, and I'm going, how come this isn't really big news? Because to me it is. And then my second question is, what's the pattern?
Well, respiratory is one of the things I've been reading about lately that's happening with younger women.
So that's respiratory, but what's the overall pattern? Where are the red spots and where are the blue spots? It's not the same as the earlier map.
No, it's not. They're more in the center, and
Yeah.
in the north and the northwest.
Yeah. So you can argue it's reality, but if you look at California, there's some really rural areas in California and they're blue. So there's an interesting pattern here. So women are dying younger, and it's not quite the same pattern as overall mortality rates. Some places are getting better, and a lot of places are getting worse. And it's not well known.
So, Lloyd, if you overlaid this with a population chart, would these be areas that were less densely populated that are the red?
You can probably answer that yourself, Ed.
I think so.
The answer is no. Actually, there is an issue because this is a delta. This is a change. So there are red areas that are highly populated and blue areas that are highly populated, and the other way around. It's more complicated.
Does it relate to prenatal conditions?
That's very good. There's something on here, and it's probably tied to prenatal conditions, prenatal care, but not care is only part of it, because again, we got some really rural frontier districts that are horrible, and we've got some frontier districts that are looking pretty good. So there's something going here we need to pay attention to. But to put an asterisk by this, it's not just about healthcare. Just looking at the map, there's something going on here in the communities with the women that we need to pay attention to. By the way, this did catch attention of federal agencies. There was actually a federal panel put together to try and make sense of this, and I'll come back to that.
Floyd, is
So,
there an equivalent one of these for men, and is it very different?
very good. I'll come back to that.
Okay.
Here's North Carolina, by the way. This one is life expectancy at birth. I'm mixing data just to show you that it almost doesn't matter what you ask or how you frame it. There's an interesting pattern. The answer is, there's something funky going on here. So this is life expectancy at birth for North Carolina. And this pattern, by the way, has been stable for years. What's the pattern?
Urban lasts longer?
Here it looks like urban, but man, there's some funky places. There's up
There are.
here in the Northeast, which is really, I mean, it's close to a frontier and it's blue. It looks like if you're in the triangle area, you're pretty good, and that's correct. You get down towards Indian country in the south east, and it's not as good, but it's almost fractal. And there's actually, that's part of my point here. If you look at the US as a whole, you can't see the pattern. If you look at states, you can see a little bit of pattern, but the more you drill down, the more you see this variation. And it's the variation that's stunning. To frame it another way, in healthcare and in clinical research, we tend to get really excited if we can make a difference in days or weeks in survival. Here we're looking at differences of a decade or more, and they're sustained, they're worsening, and we don't know why, and we're not particularly paying attention.
Does rural or population versus urban versus
So it looks like it, but again, you can see outliers on both ends. And I'm looking at the chat, folks. Income seems to play some role, and you can see that in places. Access to care, maybe, but again, there are places that are doing well that have access. It looks like it's more, you need a bunch of things to live long. And if you miss one, you may still be okay. But if you're missing a whole bunch of them, it adds up. But it's not a single thing. And by the way, healthcare goes really, and I'm a family doc about healthcare commissions galore. We tend to focus on, we need doctors, nurses, we need healthcare, and we absolutely do, but that's not enough. There's more going on here. And whatever it is, it's really big. Oops, let me do another. So let's go back. Now we're going to look at life expectancy at birth, and this is just looking at US against other countries, because maybe there's something going on here that's global. And the answer is nope. The US, for going back into the 60s, but accelerating, has fallen off the curve of other industrialized countries. Folks in the US have shorter lives. We die earlier. Women do not live nearly as long. I'll show you that in a minute. It got worse with COVID. It has rebounded, but it's rebounded to where we were. We're still years behind other countries who continue to get better. And so you could argue, well, but the US has the best healthcare system in the world. And apparently that's not enough.
So is this partly a function that we do not have a universal healthcare system? And these other countries generally do.
So the answer is a solid maybe. Yeah, and you're doing just what I hope to say. And clearly, universal healthcare has some role. If you look at the Nordic countries, that's true. And I've done work with some of those Nordic countries. I've done work with Australia. We've done similar analyses. By the way, Australia has similar patterns, except everything that's red is in the middle, where it's so rural. So even where you have universal healthcare, if you can't get it, it's not enough. But so it's yes and, or it's complicated, and access to healthcare is really important and absolute and not sufficient. Okay, let me hit this one. Now I want to know if any of the women on this group has seen this slide before. This is maternal mortality. It's a rate per 100,000 live births, 1990 to 2017. And the US is getting worse. It's completely out of range of any other industrialized country. It ranks worse than Cuba. It ranks worse than Slovenia. We are a complete international outlier. Women are dying during childbirth. in the US, and it's progressively gotten worse. And my question is there anybody on this call who knew that?
I have seen this before, and the research, especially looking at African Americans, has me very worried for the last 2 years. So thank you
Yeah.
for showing it.
It's, by the way, which group has and folks in the US, which group, women in which racial ethnic category have the best maternal mortality
Asian,
statistics? Hispanic.
Hispanic.
Yeah. So white women don't do as well, and black women don't do as well. I think I've got a slide on that.
How much of it could be due to obesity?
Well, obesity, the answer is it probably has part of a role, but it's when you look at differential rates for women by obesity, it matters. But I'm pulling up some older data, but overweight Hispanic women do better than white women who aren't overweight, who do better than black women of any combination. A black woman professor of medicine chance of dying in childbirth is horrible.
And Lloyd, Bruce Patterson, name you may know, is in several counties down east, and he says teenage pregnancies that end up with death is something like 47 times the average of North
I
Carolina.
think I may have that slide. I'll come back to it. So
Okay.
age at pregnancy matters, but it matters on both ends. Advanced maternal age is a risk factor. Again, there was a national commission looking at that under the U.S. Civil Rights Commission, basically came out with a massive report saying that there are a lot of factors going on here, and it's a tragedy, and we have to pay attention to it.
And speaking to the Hispanic population faring better in terms of maternal mortality, I would assume part of that, and maybe you have this listed somewhere, is length of time in this country as well.
Yeah. I have somewhere around 500 slides. I've cut that down. You'll be happy to know to something like 20 some. So I haven't pulled them back all up. But yeah, if you're from another country and you move to the US, the longer in the US, the worse your statistics are. Almost every case, a few exceptions.
And Lloyd, I don't know if you have a slide about midwives, and I saw a note about it, but
yeah.
that makes a big difference. And we're one of the few countries that really has a minimum of midwifery.
So let me go ahead and jump ahead to this one, because this one, there has been some drill down. It looks like the reason, there are a lot of reasons, but one of the reasons, and it was brought up most powerfully actually by the Black Moms Association, that's what they call themselves, is social support. That in the US, we focused on the medical complications of obesity, of pregnancy, which matter. But we have not focused on the experience of pregnancy and the support and the role of midwives and of doulas, promotores, in providing that. And that's probably why the Hispanic data is so much better, is for them, pregnancy is a community affair and you support the moms. It's not a medical disease called pregnancy. It's really viewed through a different lens.
In interviews that I've done, trust is a big issue among African American women.
We are going to come back to that over and over again. Yeah.
Good.
If you don't trust the healthcare system, if you have good reasons to trust the healthcare system, then, but let me share, I did this talk not too long ago at Duke Medical Center, and many of the audiences were women doctors, and every woman in the room described a horrific story of being pregnant and how she was treated as a woman physician at Duke during her pregnancy.
We have a question in the chat about access alone can't seem to explain these differences, and what other social factors.
Hold that question. That's a great question. And the short answer is we're trying to figure it out, especially here in North Carolina.
Yeah.
Okay, let me keep going. I want to point out that this is not just about racial and ethnic subgroups. The rates of death among middle-aged white, no college education U.S. adults, especially in rural areas, has skyrocketed. And there are a lot of thoughts about the reasons for that. By the way, there probably is a particularly tight tie between being white not college educated, rural, and having a very strong political belief system about people ain't paying attention to me.
How much of this is due to the opioid epidemic?
So part of it is clearly, and that's why states in particular, even more than the federal government, have been really focusing on opioid harm reduction and looking at community-led solutions around that. Because coming in saying I'm from public health, I'm from the government, I'm from healthcare, and I'm going to help you with your opioid problem simply has been largely ineffective, despite some really cool federal work. This really needs to be around community and gets back to trust and most of all, a sense of hope. Well, I'll come back to this issue of trust and hope because we're finding more and more that that's an underlying theme. We focused on healthcare and diseases. We haven't focused on people and how they view their lives. Okay, let me move away. I poured through a lot of slides and picked this one. I'm going to make the point that well, we don't always know the reasons as medical systems and public health. The folks in the community often have a good idea. I was part of a national movement that's really taken off that says we should start looking at data for where people have healthcare problems that aren't being solved, and then go to those places because they cluster and see if we can work with them to figure out why. We actually, one of the early ones was in Durham, North Carolina, and in the central part of North Carolina, where we realized that kids with asthma were clustered. They tended to live within a few blocks of each other. And we eventually figured out it had something to do with the housing projects. We did that with New York City as a state project, but it then got picked up into a national movement. What I'm showing you here is Cleveland, which is one of the interesting ones, where this is part of a national movement with Practical Playbook and the state health officers, where we were able to get the city to share actually get the health system to geomap to apartment complex where there was asthma, and we got the housing authorities to actually share their maps of where the housing code violations, and we overlaid the two maps. Now, if you can see that little red dot in the middle, but that's where there was a huge cluster of asthma and COPD outbreaks, and folks were going to the ER at very high rates, like 100 times the base rate for the city. And the hospital knew it, the primary care groups knew it, the federal cooperative health systems knew it. Nobody had any idea why. They just took care of it when they got sick. And the housing code folks didn't know because there were so many housing code violations they couldn't deal with it. So we actually got a bus and we got the folks in the healthcare system to go visit the apartment complex where that red dot is. And what you see is a picture of the visit. Nobody from the health system had ever stepped foot in any of these low-income housing projects. And the short answer, the black you see on the ceiling is mold. The place was infested with mold. It wasn't the only one, but it was the worst. It's a housing code violation. It wasn't fixed because the housing code folks were overwhelmed. So the deal here was using the healthcare data to show it was a problem and all the costs incurred by that, not all of which were reimbursed to the healthcare system. The healthcare system kind of added some political clout, worked with the housing authority and got it cleaned up. Can you guess what that did to the asthma COPD rates? Anybody want to guess what the percent reduction in asthma COPD ER visits and admissions was?
80%.
Yeah, how'd you know, Jesse?
You
That's
said
right.
it was like some crazy amount, so I was just going a little
Yeah,
less
it's
than that.
80%. It's been done all over the country now. This is the Boston data. They did similarly. An 80% decrease at 12 months for admissions, 60% decrease at 12 months for ED visits. By the way, we did in Central North Carolina, and we hit the same numbers. We had 86% reduction in the central part of North Carolina for admissions. I mean, those are staggering numbers. By the way, another question. Give me another healthcare or public health intervention that decreases hospital admissions by 80%.
Dare I guess vaccinations?
Some, which ones?
Measles?
Measles, yes. Measles, it does that. Good for you. What else? There are not very many.
Polio.
Polio. Yeah, that's it. Not flu, not COVID. I mean, those are
Tetanus.
very powerful, but the effect size is smaller. This is 80%. So here we have a condition. Here we have an issue. We have an 80% reduction. We also have a reduction in healthcare costs. It's staggering for relatively simple interventions that are paid for by folks outside the healthcare system. And it's largely unknown. See, we got a question here about oh, so those are social factors. So my point here is that there's something interesting going on that takes where you can use data to actually form coalitions between healthcare groups, public health groups, and community groups and do very effective. And by the way, this has been studied that the reduction is sustained for years because you cleaned up the cause. And yet it's been very hard to get public. I mean, I've been on CDC committees. We've it seems to be something about how we think about healthcare, especially in the United States, as separate from communities that's keeping us from being able to grab onto these, even when they're effective and they're cost effective. It's just fascinating. Okay, let me keep going. So, well, by the way, some of the states grabbed onto this. The federal agencies just had a hard time. It has to do with how they're funded and how they're structured and supported. The NIH was not interested. CDC sort of. We were able to get to some place with the Center for Chronic Disease Prevention, but only a bit. But the foundation picked it up. So there's a coalition of foundation, Robert Johnson Foundation, the Beaumont Foundation, which is the biggest public health foundation, ended up with about 15 foundations that actually supported community-led interventions for the community to say, what are the healthcare things they're worried about, health outcomes, and then to bring in the healthcare groups, the public health groups, the data, they actually design interventions. The Build Health Collab Challenge is one of those. I actually managed that for many years, working with about 1,000 communities across the United States. And what was interesting was that they were competition. Folks had to say what the issue was. They had to show the data. Then to get funded to do the interventions is we just had an outpouring of community interest. Our hard part was getting the healthcare groups and the public health groups to play, but having big foundations and money behind it helped. But we were able to put these together, and they're in almost every state. You can look up those. Durham, North Carolina is one of the current awardees, I'm happy to say. And we did get some attention from County Health Rankings, which is RWJ funded, and then again, a little bit with CDC, saying this is what the model really looks like for improving health. It puts the community in the middle. And then it says, all of the rest of us, public health, healthcare, business, educators, philanthropy, we're all there to support the communities. And the community is not a state, unless you're Rhode Island, maybe, but it's whatever group of people share a common sense of identity and a desire to work together. And there's some very technical language we've come out with about how to define that and measure it. But saying the community's in the middle, they own the problem, they live and die with the problems, and we need to be supporting their figuring out what solutions work for them. And part of the reason this matters, I said we're going to come back to trust, is trust. Because healthcare has gone down the route of we need more doctors, we need more hospitals, we need more money, all of which is true. And public health has gone down the route of we need to do studies and figure out what solutions, then we're going to tell people what they need to do, which also has truth to it. But if people don't find that truth speaking to them, if it doesn't just speak to the narratives of their lives, then there's a loss of trust. So the issues that we faced about mistrust have landed on an already existing, long-standing, steady decline in trust in science, in universities, in healthcare systems, and in hospitals. And it goes back for years. In large part, we have not been listening to the people that we're supposedly helping. Instead, we've been trying to figure out what we think makes sense and telling them to do it. And that's a really crappy way to get things done. And we've seen it play out post-hurricane. We've seen it play out post-COVID. We're seeing it play out right now of the trust in academia and healthcare federal agencies has simply been decayed. But by the way, the group that stands out, there's actually two groups. One of them is on this slide. The one that is fire departments. Because fire departments, they don't tell you, ask if you paid your premium, or if you're in their service area, you call them, they show up and they put out the fire. So there's something about responsiveness to need that matters. The other group, this one's more culturally based, is churches have maintained some degree of trust, but only among those who are church affiliated. It's otherwise declined. But look at the data on universities. Oh my God. Same with social service agencies. I've been working with the state of California on their concern. And what the state of California figured out is that the social service agencies basically were underfunded, overwhelmed, and basically said, you show up for us and we'll tell you what you need to do. And boy, if you're a gay or trans adolescent in the Valley of California, and that doesn't work for you. So the suicide rate in the Central Valley of California in adolescents is sky high, despite having funded services. Maybe not enough funding, but people would stop going because the trust wasn't there. Questions about this? This has really caught the attention of academia and obviously of some of our federal agency heads about the importance of trust, and they're right. No question. Okay, I'll keep going. This is some WMC data about trust. And again, it's trying to break it down, showing that there is some trust. For instance, it's declining. There's still trust. You're going to trust hospitals more if you're white than if you're black. If you're a baby boomer, if you're Gen Z, you don't trust hospitals or doctors that much for that matter. If you're lower income, your trust levels are going to be lower. If you're, no surprise to this group, if you're black, you don't tend to trust police departments a whole lot. No big surprise there. The group that has the highest trust are highly educated, white, males in particular, living in urban areas, and I would add parenthetically that they tend to be the ones making the decisions. So it works for them. The problem is it doesn't tend to work real well for others. Comments?
The change between, or the difference between boomers and younger people, Gen Z, Gen X, etc. I mean, part of this seems to be lived experience, but it also may be a reflection of a person's perception that very day, that very week, of what do these institutions do for me? Whereas if you have a longer experience, you may have seen a little bit more of that.
Could be. And here's broken up a little bit more. And Gen Z basically doesn't trust anybody. As I remember, the university Gen Z number wasn't big enough to analyze, but the short answer is, Houston, we got a problem because the younger you go, the lower the trust levels. The more conservative you are, the less you trust universities, healthcare systems. The point I'm trying to make is it's not pervasive, but there is an underlying issue of loss of trust, a loss of sense that the agencies that are supposed to be in organizations serving us, supporting us, aren't there when we need them or doing things in ways that we find helpful, and that it's getting worse. But again, I don't want to overstate it. There's an underlying level of some degree of trust, but again, the older you are, the more white you are, the more urban you are, the more educated, the more higher income, your trust levels are going to be higher, and the less you're any of those, the less likely it's going to be.
How much of that is the skill that a person might bring because they have more education to be able to pull the levers of the system?
It could well be that, again, we're now going to move into what we're doing about it because that's underway. But this issue about how to make things accessible to make it so that you can navigate the system. I would add, and I think there's probably everybody on this call knows, man, I'm a family doc. Was medical director. I've been a department chair. And one of the major jobs I had as a department chair, as a physician, was helping people navigate the healthcare system, including my own family members. I mean, even if you have a PhD or MD, navigating the healthcare system is nigh impossible. So it helps, but clearly we got a big problem. And that's part of the point I've been trying to make across federal groups and state groups is, guys, this is not a mind problem. This is not just a problem of misinformation. This is not something in which we can write a white paper and fix. We have a fundamental worsening problem of engagement, of people feeling like want to, they know how to, they're able to navigate systems that are that should be there to help them. And we need to figure out how to resolve that and how to deal with that effectively. And that includes universities. So I mentioned there's been work underway. It actually started very formally under Obama 1 and continued under Trump, Biden. It finally finished under Trump 2, got laid down early in those days. That basically said we need to figure out how to engage with people. And this work was actually sponsored by the CDC and NIH. It came out of the Environmental Justice Movement, ASTDR, ATSDR. I was the lead on this second edition, which has been downloaded 10 million times now. Basically saying that there's a method to engagement and that it involves going to people and listening to them and trying to work with them to solve the problems and that it works. So we cited deep literature, multiple examples, tribal, rural, urban, Black mothers, saying there's a method to this. It's not just good intentions. In fact, good intentions tend to get you in a lot of trouble real quickly, but there's a process that is really about being trustworthy, to use some other language. And then we need to be learning this within academic centers. We need to be learning this in public health. We need to be learning this in the healthcare systems because being right is not enough. You actually, if people don't know how to navigate it, don't trust you.
In one of your photos slides, you showed there were a lot of women involved, and I remember a nurse here here at North Carolina Central had worked hard with men because they had a concern, such as Henry, the drilling guy, that men don't want to see a doctor. Yes.
Yes. Yeah, there's actually a film that's just been released. Some of you may have seen it. It was shown at Duke 2 weeks ago, and it talks about kind of cultural ethos and about the role of academic systems, academia, and dealing with connecting with those cultural norms, those groups, and finding solutions that work for them. It's being shown at Gillings actually on March 25th. I just got that announcement a little bit ago. We're going to show it at Duke and School of Medicine on April 12th. But I guess what I'm trying to share here is that I've shared problems which are really severe and worrisome and not getting better. Now I'm shifting to talk about what's underway because there is hope here. I want you to feel that hope. And in fact, North Carolina is one of the places doing some of the coolest work. But I wanted to paint the picture now because the problems are deep-seated. The solutions are actually already known, are already underway. And one of them is it relies on engaging with communities who are diverse, different, and but going to them, listening to them about what they want and sharing data and looking for data that isn't being gathered or isn't being interpreted correctly and making sure there's a shared understanding about what the problems are, what the data is, and what folks want to do about it. And that's underway across the country and especially in North Carolina. But I mentioned that there were Principles of Community Engagement. That's the book. This is, let's be clear about why you're engaging with communities, partner with them. It's a long-term commitment. I won't go over this. You can, by the way, all the stuff I'm sharing is online and available for free. Principles of Community Engagement, second edition is still up on the CDC webpage. There's a third edition that's Trustworthiness. The CDC took that down for reasons that escape me, but it was released and it's actually online in multiple places. Let me go. Oh, there's 10. Yeah. Trustworthiness, that's the third edition, is fundamental to sustained engagement. So it's not, trust sounds like it's a problem. People need to trust us. It's actually the other way around. We need to earn their trust and be trustworthy, and that's our job and our responsibility. So the National Academies picked this up as a major theme. They spent 5 years. Actually, first they put together a group of academicians who were concerned about that. I was one of those. And then we said, wait a minute, we need to practice what we preach. So we actually got the National Academies to pause the work and add in a equal number of community leaders from across the country, from every imaginable group. And we restarted over and said, what is it about what makes engagement work? What makes it so the community feels like this is meaningful to them? And we spent over a year hashing it out, coming up with models, and then we actually hired a graphic designer and worked till the community group said this, okay, we understand what we're saying, and this works for us. And the basic point here is that you improve health, you transform systems of health by starting with the community. That's that center of that's the axle. And there are principles about how you do this. And so this work is intentionally and directly linked to that principle of community engagement. It's about trust, it's bidirectional, it's inclusive. Governance is shared. I'll come back to that theme because it's playing out. It recognizes multiple sorts of knowledge. It's not just scientific knowledge. The wisdom of the community and its history is important. And that engagement leads to strength and partnerships. That's that first blue petal. And expanded knowledge that shared improved health and policies thrive, the communities thrive, and then you achieve health for all because you change the systems that affect people in their communities so that everyone has a chance to be healthy. So this, by the way, this got picked up again by federal agencies and got disseminated across, oh, I forget how many, 10, 12 federal agencies, including NIH and CDC. So this is now up and picked up. NIH has referenced it. CDC has referenced it. But the point here for this group is the centrality of the community, and then I'll come back to the role of data and informatics in that. So let me just share that there's numerous papers. AJPH asked me to write an editorial form about what the key lessons are. So let me summarize that, which is the way you do community engagement is you start. You don't plan forever. You actually go to community meetings. You don't ask them to come to you. You go to them, and you listen. And the listening turns out to be really important. You're listening not just for what's wrong and what people will work on, but what are they proud of? What do they see as things that they value in their priorities? You learn what's already underway. The mistake I see academic groups doing all the time is they start new things, not realizing they're duplicating what's already there and they're causing damage. And notice number 3 is you use data to help define, you share data that they're, and you have it validated with folks with lived experience. Data on maternal health is a striking example where the data was being collected by health systems often was completely at odds with the lived experience of the mothers, because the data that was being collected was not asking the questions that were relevant to them. And then you jointly build capacity. You work on things together, start small, build programs together. They co-led. In fact, the new model is the community leads, academic groups and public health groups and state groups support that. And you learn together. It's a journey. It's not something you just do and you're over with. It's a transformation of how healthcare groups, public health groups, and governmental agencies work with communities. And it's underway. Even in this crazy time, it's underway. Questions?
Kind of a comment. So you talk about data to inform discussions, but sometimes one person's data is incomprehensible to another person. I mean, the analogy in economics is if my neighbor loses their job, we're in a recession, but if I lose mine, we're in a depression. And so how is it used to engage with community groups so that it becomes a useful tool?
That's a great question. You set me up. Thank you. So there are coalitions underway across the entire United States, and Jesse can probably speak to this more than I can, about shared data, not just sharing data across healthcare systems, which is how it often started, but increasingly it's sharing from multiple components and it's sharing it with community groups. So you're having a back and forth. What does the data say? And how does that jive with lived experience? You'll hear that term lived experience a lot. And it's a tension. It's a back and forth. And it's not just asking what does data mean, but what data is missing? What data isn't being gathered? And this came up really powerful in COVID because, and you guys know this, but the original data being collected on COVID was largely being done of who was showing up for testing. And it was largely people who had money, knew about it, had transportation. So, and there was no testing being done in minority communities. So the data was completely misleading. So it's a dialogue and discussion, but a crucial issue is that it's got community voice in that, back to the centrality of communities, and it's putting together systems to share data, gather new data, exchange it, and agree on what the data means. So it's a discussion. Jesse, you want to add on this? This is much more your space than mine.
I was worried you were going to say that when I wasn't able to get to the mute button. No, I would say I think that's a great summary, and it gets confusing because there's a sort of murky space of like there's HIEs and CIEs and SHIEs, and they all have subtle differences, but fundamentally working toward that data exchange, whole person health. That we've got a long way to go, but at least people are starting to think in that direction.
And thank you. And the point I want to make here, because I sit on a lot of grant review committees, is I'm now, this is me speaking, not federal agency. I am so sick and tired of reading grants from some academic group or health system that says we're going to set up a data system so we can figure out what's going on in the community and tell them what they need to do. It's already there. And you're not trusted. I mean, for God's sakes, don't reinvent the wheel, but join what's already underway, and partner with that.
So this sounds, I mean, because I'm looking at my students thinking, okay, this is an approach that links community sources that are, shall we say, far beyond electronic health record plumbing issues.
I'm sorry, I couldn't hear that last part.
It's far beyond just
yeah,
EHR plumbing issues.
It includes EHR data because it's the most granular. You can do household mapping, but it is way beyond EHR data.
So how should students who are studying to become health informaticians consider this opportunity?
They all ought to work with Jesse. But I say that tongue in cheek, but only partially because, and Ed, I would add, Ed was always good about this. It's saying that the healthcare data is really important. And as you know, what our doctors know about us is only part of our life. So it's adding in housing data and employment data and transportation data. And that gets really messy because they're different domains and adding it, but it's to participate in something larger than looking at healthcare data as truth alone. And that's underway. In fact, I'm going to show you some examples of that because one of the positives in all this destruction we've been underway is some of the ideas that the idea that once you have healthcare data, you can identify the truth and find effective solutions has pretty well been stopped. So increasingly, the federal efforts are really about pulling in data across multiple systems and multiple sectors. And it's underway. It's incredibly convoluted and complex. And Jesse can talk and knows far more about this than I, but it's underway. So I think for the students, if I would be worried about a system or working in a group that we're going to analyze healthcare data at large scale, and we're going to figure out underlying causes of diabetes or hypertension. I mean, it may work for Fanconi's anemia. I know that one reasonably well because that's it. But even in the things that are related to genetic causes of disease, it turns out the causes of death or premature life are often not related to disease. We saw that in cystic fibrosis, where data analysis and folks that men weren't going to cure cystic fibrosis. The reasons kids were dying of cystic fibrosis once they talked to the moms was that they were malnourished. So they actually had to, again, the point is be part of a group that includes more than the academicians and healthcare groups. And Jesse, I see your hand.
Yes, sorry, I wasn't able to get off mute to say thanks for the shout out. Unfortunately, and this is related to a question I want to ask you, is I'm barely funded myself these days, and it is a crappy time to be applying to NIH for this kind of work. Equity related, et cetera. So, Lloyd, do you have any wisdom and insights?
Jesse.
Okay, great.
I do have some suggestions, and feel free to push me back. One is there are two forces underway: is overall destruction. I mean, the old system being ripped up, defunded, and I'm going to come in. You can see bright spots in which the new systems are being created, and I'm going to call a couple bright spots. And the NIH is one of them. And it's particularly the Clinical and Translation Science Awards. I'm going to show you some language around that, which have started to weave in this idea of partnerships. So you mentioned, had mentioned in the beginning that was a part of the founding of that program, the National Academy review of it. I'm still a reviewer for them, even under the current administration. But they have changed to say there has to be community engagement throughout the research program, including defining the goals, what data is gathered, how it's analyzed, and how it's implemented. So there has to be systemic involvement of participants, patients, communities in that. So, and those are still being funded. And there's all sorts of headaches about indirect rates and all, but it is being funded. It is not where do I put it? It's very messy if you're in a blue state and the current administration is mad at you. But they are being funded, and this issue about data and engagement is it's in the FOA. And in fact, part of what we do in the review committees, and basically our feedback is, did you read the FOA? Because it's there. So one of the reasons I want to do this is that folks are continuing on their old pathways, not realizing that this issue about engagement is actually is there across the agencies, and folks aren't seeing it because of all the other craziness. But it's there, and they're not not getting their hands on the money that is there. Okay, let me do some others. This is a new NI statement by Jay Bhattacharya about trust and confidence in research that came out recently. I've given you the links, but it includes, look at clinical care data research principles, recognize the needs of communities from which the data are collected and generates imperative to respectful collaboration or partnerships for using clinical data for research. This is guidance to every NIHIC. And I would add that many of the old IC directors did not see the relevance or value of this approach. And I do not mean to defend the current craziness, but I would note that the people who simply didn't see the value of this are no longer there. So there's a sea change underway, and it's much more, there's a lot of craziness, but there's also a shift to saying, no, we're going to do things with communities, and we're going to do things respectfully, and we're going to earn the trust, especially in those areas where trust has been lost, in those communities where there's a sense of, these research groups simply don't care about us. Jesse, is with me? By the way, I'm fascinated
Yes.
that few people know about this NIH missive. I think because there's so many executive orders and missives,
Yeah,
most
we
of
can
which
keep track.
are just painful. This one is not. This one is on target.
This is great. Thank you, Lloyd. I wasn't familiar with that.
Okay, so here's another one. This is a new guidance to the ICs about what they're to put in their new FOAs, and it came out on January 12th, 2026, expires in a year. So this is a trans-NIH goal to improve bioethics research projects that are actionable, build trust, and enable better integration of bioethical principles into biomedical and behavioral research. Specific research areas include artificial intelligence, y'all, and then look at number 2, research engagement, which includes approaches for this is a cut and paste. Approaches for effective community engagement, co-developing research priorities, building and sustaining research trustworthiness, and recruitment and research and access to clinical trials. Coming to a IC near you.
The question of using artificial intelligence, as you note here, does bring up the issue of data privacy. And,
oh, yeah.
And if I were a health informatician doing research and development in artificial intelligence in healthcare, does this mean that I need to download open source versions of artificial intelligence and ignore the big platforms because all they're doing is backing up data?
You're above my pay grade in knowledge. Short answer is I don't know. I would share that I've been on panels that have reviewed AI proposals and rejected them because the community wasn't engaged in deciding their priorities and wasn't engaged in validating the models. So I gave you a different answer than the question you were looking for. Short answer is I don't know. Let me speed up a little bit because I don't want to run out of time, and I've got a couple other resources I want you to know about. PCORI, I think you know about. They've redone their fundamental expectations for partnerships. You don't get a PCORI grant unless you're deeply community engaged, and that includes in analyzing the data and what it means and what data is missing. That's fairly new. And then this is the big one I want to pick up on and then talk about North Carolina. So CMS, not a research group, announced their $50 billion in awards for rural health in all 50 states. Made clear, this is a reduction in funding for the states. This is a reduction in funding for rural health. All true. And it's a repurposing of the funds, reawarding of funds for community engaged health communities and rural people in rural communities want healthcare to be. And this is actually from the announcement of what we're looking for. They want care within reach. It could be in person, it could be vans, it could be telehealth, a rural clinical workforce, which could be broader than doctors and buildings, research, the health infrastructure, including IT, empowering the providers who are there, including comprehensive data sharing platforms and partnerships, and advancing alternative payment models, not just fee for service. So that was the funding announcement. The awards have been made. This is North Carolina. It's $200 million per year for 5 years, so $1 billion. And there was a meeting last week. Some of you may have listened to it and announcing the rollout of this, but you'll see some themes. There are 7 regional networks called Roots that are locally governed, community tailored networks, and there's asking for applications for those now because they have to award the money, I think, by September to get those up and running. And they're going to be medical, behavioral, and social services integrated, but led by the community in those areas. They have to describe and implement programs to improve prevention screening, chronic disease management, maternal health, and nutrition. It has to include behavioral health and substance use disorders in those models. It includes enhanced funding for rural training, fellowships, and certification programs to build out a rural-focused workforce. It shifts the model from fee-for-service to value-based care for the rural primary care groups. And it has a lot in there about technology, innovation, access, broad implementation of AI-based technology. And the money is awarded. They're having sessions right now about the requirements to get the money. And I think the first awards have to go out by September. So $200 million for North Carolina, and it's for 5 years. So folks are picking that up and running with it. There's a group at the Associated Academic Medical Centers that's picked this up, and we're trying to help academic medical centers learn how to do this. And they've done some really great works, including toolkits on engagement and what it looks like and how to do that. Almost done. And what it comes back to, if I can leave you 2 things. One of them is hope that there's things underway and funding underway, but it's different. And the other is the importance of trust and engagement. And the Director General of the World Health Organization made a really great comment. The WHO is paying attention to this despite the U.S. treatment of it, saying, and this is a quote, "We must make sure that when we seek the trust of others, we ourselves are trustworthy. We cannot assume or expect trust, we have to earn it. And that begins by listening to people we serve to understand their needs and preferences and the reasons they believe mis and disinformation." So that's my message to you, that we're in a different world now. And it's really around building that trust engagement, and the data is central to that. But it's data with the communities that about whom those stories are told with the data. Let me stop there because we're almost at time. Questions? No, I'll give you some references, but this is underway.
Just a comment, you ended with a quote from the World Health Organization, which I believe in 1948 passed a resolution that healthcare is a human right. It's not a business, it's not an opportunity, it is a right that everyone has. Which seems to be a thought underlying everything you presented today.
Yeah, it is. But it's the shift that I'm describing is it's not health care as designed by people who think they know what people need. It's healthcare as a right to the service that people want and help them. So there's a science aspect to this. There's absolutely a need to listen to what people want rather than tell them what we've decided they need. And I'd add, because I did a little work with WHO through this whole process, that WHO also has some pretty strong language about the need for primary care to be community oriented, which in the US it is not. And it very much is in most every other country I know. So
Well, thank you very much. This has been a remarkably helpful seminar.
Good. I'm happy to follow up with folks. Again, please, that we're in a new era. Come help us. We need it.
Okay. Thank you, everyone.
Thank you.
We'll see you next week.
Thank you.